want to tug on the brachial plexus or anything. I just want to open up the space, internal external rotation. I can do small little oscillations. I can do larger oscillations, whatever my patient can tolerate, because I'm going from movement. I always test and retest. Everything I do, test and retest. Whatever's painful, I'm going to retest it when I get finished. So I might start here, and then my goal is to move them in a more functional position, maybe to here. So now I got to switch my position. I'm still going to sit down. I'm going to come around here now, and I can support the arm there. And then I'm going to push the humerus away from the acromion. The acromion is here, right here where my hand is. So I got to figure out a way to get my hand positioned to push the humerus away from the acromion. And it's the same thing, internal, external rotation. Okay, that might be painful. That's what? That's close to 90 degrees. That might be too much. All right, so maybe I'm moving down. I thought my chair was going to roll in front of the floor. So I bring it down a little bit. That's close to maybe 30, 45 degrees. So the same thing. I push the humerus away from the acromion and there. So I can move it up, I can move down, I can change position. If I want to do more flexion than abduction, I can bring it here in this position, but always trying to maintain that subacromial space and move. Right. So that's the idea. What do I do? If I want to show them how to do this at home, what do we call that one? It's just doing, what is it called? What's it called when you do this? Codman. That's it. How did I forget that? Just maybe a little weight or something and just moving. Right? Moving, a little distraction. Open up that space and get me some movement. So one of the things that this patient, can you mind saying here? You can stay right where you're at. One of the things the patient had was a limit in internal rotation, right? 15%, not a big limit, but that limit could be one of the things that contributes to subacromial impingement. So patients with posterior capsule, and that posterior capsule is tight, that tends to move the humeral head more in a superior direction. So I definitely want to manage. So there's multiple things that I can do, but I'm running out of time, so I'm going to show posterior capsule stretch, right? So I got a quick test that I can do. So this patient, when I did the evaluation, had a little bit of motion limit here, but I want to do something to really confirm that there's a limit. As I said, that sometimes that could just be the scapula. That could be something other than a true limit of the posterior capsule. And so I show here a test, which what I do is I bring them up to about 45 degrees, stabilizing the scapula, and looking at how much internal rotation they have from this position here. So the motion is there comparing from side to side. Now, if I see that they have a little bit of limit with internal rotation during my exam, then I go back and recheck them, and maybe the infield is a little bit more firm, maybe there's a little bit of tightness, then I can go in and I can stretch the posterior capsule. How many people do different posterior capsules? This is something very common in physical. Posterior capsule stretch, great. So what I'm gonna do is I'm gonna use some arthrokinematics, and I'm gonna push the humeral head in a posterior direction. So when you internally rotate, the humeral head rolls in an anterior direction, and it's gonna slide in a posterior direction. So my mobilization technique is gonna be a posterior slide. So I'm gonna put them at the in range of internal rotation, that's what it shows here. So the position is whatever they're in range. So if they can't get their hand behind their back, then I'll just, okay, loop your hand here in your belt loop. That's as far as you can go into internal rotation. And then what I'm going to do is I'm going to add a stretch by pushing the humeral head, so they're here, internally rotated to the in range of motion, and then I'm going to push the humeral head in a posterior direction to stretch the posterior capsule. Got option one, which is with the patient positioned in internal rotation. Option two is using horizontal abduction. I'm going to show both of these. So first, so behind the back. Can you go right there? No problem. Okay. So there's so let's say his in range of motion of internal rotation is there. I'm going to find my posterior direction. It's coracoid to his acromion. My thumb is on the coracoid, my middle finger's on the acromion, and that gives me my direction for my posterior glide. So my arm is lined up in that posterior direction, a little superior to. So that's what I'm going to do. My glide is, there's my stretch. And so my motions, my oscillations. I can take up the slack to the end range of motion, and I can do some small grade 4 oscillations, stretch the tissue. And then I can go back, always, I can go back and recheck the internal rotation. Option 2, on this side, I'm going to come on the opposite side, and now I'm going to horizontally adduct the shoulder while I'm pushing in that same posterior direction. As I'm horizontally adducting, so I'm pulling this way across, I'm pushing the humerus in that posterior direction to get a stretch. Now this one I'll do this rhythmically. I can do some oscillations, but I'm just trying to get them to there so I feel like I'm getting a good stretch. So I supinate to get my hand right in on the humerus, and then my arm shows the line that I'm pushing in. There's my posterior capsule stretch. So either internally rotated or moving into horizontal adduction stretch. The other thing with this, is if the patient has a limited internal rotation, I'm trying to do transverse friction massage, and I can't get them into this position, so I might have to do my stretch first. So what my treatment may look like is just some